these days, just hearing the word emergency is enough to unsettle many Nigerians. A health crisis, a road accident, a sudden disaster, and any situation where help is urgently needed often comes with a troubling question. Will help actually come?
Well said. And for many, emergencies are not a matter of if, but when. When they occur, attention quickly shifts from incident itself to something just as critical: the reliability and effectiveness of Nigeria's emergency response system.
Successive governments have made attempts over the years to confront this challenge, particularly in the efforts to reduce avoidable deaths. Yet, for a long time, progress appeared slow and largely uncoordinated.
That narrative seems to change a bit in February 2022 when a glimmer of hope emerged. The Federal Ministry of Health entered into a landmark collaboration with the private sector and other key stakeholders to operationalize the National Emergency Medical Service and Ambulance System, better known as NEMSAS.
It was designed as a collective effort, institutions such as the National Health Insurance Scheme, the Federal Road Safety Corps, the Guild of Medical Directors, and the Federal Capital Territory Administration all came on board, with Abuja chosen as the pilot location.
Now, 3 years on, questions are beginning to surface for a system expected to operate across 3 critical pathways: emergency response on highways, coordinated services within states and the FCT, and interventions in workplaces, sports and assault-related incidents. Many Nigerians are asking whether the impact matches the ambition.
That's a good question. So what exactly is NEMSAS meant to deliver? How far has it progressed? And what are the challenges standing between intention and execution?
And those are the questions we will be examining this morning as we take a closer look at Nigeria's emergency response framework. Welcome to Good Morning Nigeria. All right, it's still Good Morning Nigeria, live on the network service of the NTA. And just before we get into our conversation this morning, let's quickly take a background report put together by our correspondent Ibrahim Bello-Gunda.
Nigeria's emergency response system is a multifaceted network of government agencies, private organizations and NGOs working together to provide relief and support during crises. With more than 40% of Nigerians living in rural areas with limited access to healthcare, the challenge is not just treatment, but timely access to care. This, of course, is arguably one of the leading causes of preventable death and avoidable complications. The National Emergency Medical Services and Ambulance System is a Nigerian government initiative to provide free, timely emergency medical care by simply dialing National Emergency Number 112, covering the first 48 hours of treatment for critical patients, all aimed at reducing mortality by integrating and providing emergency response. This is expected to be achieved through partnership, better technology, and enhanced coordination with agencies like Federal Road Safety Corps, National Emergency Management Agency and hospitals, focusing particularly on vulnerable groups like victims of accident, natural disaster, pregnant women, and children. A study shows that despite flagging of the initiative, challenges persist, including limited public awareness, with only 38% of Nigerians knowing about the 112 toll-free emergency number and 57.8% of respondents aware of emergency medical services, while 42.2% are not aware. Infrastructure gap like poor roads and insufficient ambulances hinders rapid emergency response, inconsistent state ownership, with some states being slow in adopting the initiative, thereby affecting its overall effectiveness. Lagos State Ambulance Services has also shown promising results with a 97.5% emergency response rate between 2021 and 2025. However, this service faces challenges like delayed response times, inadequate infrastructure, and attack on emergency personnel. How effective is Nigeria's emergency response? What is needed to make medical and other emergency accessible even in rural areas? And why are the National Emergency Medical Services and medical system yet to fully kick off across the country? These and more are some of the questions guests on Good Morning Nigeria will find answers to as we take a look at effective emergency response in Nigeria.
Thank you very much, Ibrahim, for that background report. And I believe that the guests have listened to your background report and the questions that you have asked, and they are ready to prefer solutions, answers to those questions. Let's kickstart by introducing our guest in the studio this morning. In no particular order, let me just introduce Moji Makojuola. She's the Executive Director and International Society of Media in Public Health. Madam, you're on the other side now.
Yes, I'm on the other side, and right. Okay, I'll try and take the heat.
All right, thank you so much. Good morning.
Good morning, Nigeria.
Also joining us in the conversation is Dr. Okonokwa Ozi, is the Program Manager, FCT Emergency Medical Service and Ambulance System. Dr. Okonokwa, good to have you join us.
Thank you for having me this morning. Good morning, Nigerians.
Good morning.
All right, also joining us for the conversation right here in the studio is Dr. Usman Adamu Ugwaram, Chief Consultant General and Trauma Surgeon. He's the coordinator, National Trauma Center, National Hospital, Abuja. Many thanks for joining us.
Thank you very much. Good to have you.
All right. Also joining us for the conversation, but not right here in the studio, via Zoom from Yenagoa, is Professor Siefa Brisibe, Honorable Commissioner for Health, Bayelsa State, and co-chairman, National Emergency Medical Treatment Committee. It's a pleasure to have you once again, Honorable Commissioner. Many thanks for joining us.
Having me, and thank you. Good morning, Nigeria.
Yeah, good morning. Let's stay with you, Prof, because you are the co-chairman of this initiative. Tell us the philosophy behind it.
Yeah, the philosophy behind it is, one, to increase access to emergency care, and two, to enhance pre-hospital and emergency first 48 hours emergency response in hospitals, and three, to ensure that people do not spend money out of their pockets when they need emergency services, because one of the serious determinants of outcomes is when people go to hospital and they are made to source for funds. So basically that is to expand access, to see that people do not spend, there is no financial barrier between people that have emergency needs and care, and also to see that referral services are out of the way. So those are the basic things that the emergency, our National Emergency Medical Treatment Committee is supposed to do. And of course, it's one of the gateways for the basic healthcare funds. And it is basically to see that people do not die. When they are transported, when they have emergencies, they are transported safely, and people are trained as well to provide that pre-hospital and immediate hospital care at the same time. That is the philosophy behind it, is to save lives.
Professor Brisibe, for your opening comments, to save lives, fantastic. I'd like to get to Dr. Okonokwa Ozi right here in the studio. If I'm correct, I'm sure this program, NEPSAS, began in 2022, October 14 to be precise, right? Speak to us about the progress so far, or the success stories so far.
Okay, interestingly, since it was flagged off in the FCT was used as a pilot state in the year 2022. It has been rolled out. What we say is that a couple of states have been onboarded, onto the scheme across, Nigeria. I would say we have about over 20 states have so far keyed into the program. And the idea is to see that across the length and breadth of Nigeria, nobody has a need to pay for emergency medical services, before they're able to access care. In the FCT, for instance, since it was flagged off in 2022, we've been taking concrete steps to see how we can cover the length and breadth, of the FCT. The idea also is to ensure that Nigerians are even aware of this initiative, because since it was flagged off in the FCT, just like your report said, a lot of Nigerians still do not know, and they don't believe that this thing is actually working. Case in point is that at our call center yesterday, a young lady called, and when the call went through, she was so excited. As you mean, Nigeria actually has an emergency call number that they can actually call. So it's working. It's spread across the length and breadth of the country. I think, if my record serves me right, we have just about maybe 3 or 4 states that have not formally keyed into the program. But efforts are being made to ensure that all the states of the Federation actually have access to emergency medical services at the call of a number. The ideal number that is available for us to call is the 112 number. That's the national emergency number that everybody can put a call across to. But states have also gone beyond the 112 number, because sometimes you may put a call across to the 112 number and then there's a challenge. So what happens is that every state has been encouraged to have an 11-digit number, that Nigerians can call to access care. If the 112 number is working effectively, you don't need to have a backup 11-digit number. But we don't want to keep Nigerians waiting and stranded, and that's why all the SEMSAs across the length and breadth of Nigeria have been encouraged to get 11-digit numbers through which Nigerians can access, emergency call, ambulance services at no cost. At no cost, whether it's picking up the patient from the point of accident to the hospital. And just like the co-chair of the Emergency Medical Treatment Committee just said, for the first 48 hours as well, Nigerians are not expected to pay. However, this must be at designated hospitals or emergency treatment centers. It's not just any center that you can walk into and get this first 48 hours treatment free.
But accident can happen anywhere. So when you say designated centers, I want to ask how many centers are designated. Then your earlier response when you said most Nigerians are not aware. What effort has been made to get Nigerians aware about this?
Well, we are here.
Before now.
We've been on this beat for a long time, going around sensitizing the public. We share information across the length and breadth of Nigeria. There are, media, social media platforms we're also employing to see that Nigerians, are able to get this information across. Now, to answer your question about how many treatment centers we have, it is not actually the number of treatment centers that is as critical as getting persons from the scene of the accident to the nearest treatment centers. All the treatment centers in Nigeria, for instance, the tertiary hospitals are designated treatment centers, just as well as most state hospitals have their secondary healthcare facilities as treatment centers. We've also gone beyond to ensure that even private hospitals that meet the requirement are also onboarded as treatment centers. But the critical aspect of it is conveying the patient from the scene to the nearest treatment center. So you may have more ambulances than treatment centers if that is going to work, because that means that at every location there should be an ambulance, and that's where the role of road safety actually comes in. Road safety has actually helped to also bridge this gap. We are very much aware that road safety has a number of ambulances that are on some corridors, especially corridors that are notorious for accidents. So at the call of they also have a toll-free number, the 122 number. So once you call the road safety as well, or we call the road safety, we leverage on their coverage to be able to convey accident victims from the scene of the accident to the nearest treatment center.
Okay, thank you very much, Dr. Okunukwe. You talked about that every Nigerian should have access to free medical services the first 48 hours. And but just like my colleague noted, the awareness is not there. Mrs. Makojola, you've been in this awareness business for decades, and how do you, because this program started in 2022, that's about 3-4 years ago, and the awareness, not many Nigerians are aware of it. So what exactly is stalling, the implementation?
I think the initial rollout, was not quite clear in the sense of community engagement, bringing stakeholders together, and fashioning out strategic communication and media engagement, and of course community engagement. So what the NEMSIS has done, which my vice president just spoke at the beginning, is that there's a deliberate component of NEMSES that is addressing communication, messaging, community engagement, and of course regular stakeholders meeting. Okay. And this has been coming on since we started meeting as NEMSES. But most importantly, for the media, let's talk about us now.
Yeah.
We have become a strategic tool that would contribute to creating awareness for these emergency health interventions that you can get anywhere, anytime, even at the lowest of levels, that is at the rural area. At the moment, we have what we call NEMSES Media Cell.
Okay.
Selected media organizations and individuals that have proven themselves, particularly in reporting health and development. They have been brought on board, and they are the people that are going to be the foot soldiers to be able to disseminate information. Like my colleague there from the FCT said, there is also a deliberate movement that is happening now. And I'm sure that some of these things we can share with you, I don't know if on the social media, jingles, variety of messaging that is going around, and in local languages.
We've not been seeing this.
Well, you've not been seeing it on network news, but some of them are out on social media. Well, we can give you, Okonofa, please, can you give them some of these? That let's start with the FCT.
Okay.
That's the pilot state.
Okay.
That's where it all started. It was silent initially,
okay,
but there's a whole lot of work that is going on now to create more awareness going forward. And the good thing about this is that it has an integration with the National Primary Healthcare Development Agency, with the National Health Insurance Agency, with, of course, FRSC, so that there's an integration that is happening, which will give louder voice and better coverage as we go on. But what you're doing, NTA, and thank you for bringing us on, very first week of the new year, is also associating with the fact that everybody has a responsibility. It's not about you and I. If you know that this is the call number, or you have the need for an emergency,
okay,
you know where to call. And this has to be a collaborative thing, because it's new, so to speak, in Nigeria. We have always been very orthodox in things that we did. But now, with the reform in the health sector, things are fleshing out. And emergency intervention is an imperative. We do have challenges in terms of course, it's a multi-sectoral thing. It's not about just Ministry of Health or any of the health facilities. It is about good road. It is about awareness, like we are creating now. Thank you. It is about collaboration. It is about education. It is for you to know, and the you to know is what we are, and that's why we're excited to be here this morning. It's on. You might say that it's not as loud, but this year there are plans to make it as loud as possible, so that everybody, and the interesting thing is it's going to be in Nigerian languages, so that it's not elitist in its intervention. It's something that will speak to you and speak to I and speak to that woman at the rural area. And let me tell you something before, the excitement for us is that it's working where people are aware. We're beginning to see less of our mothers in complications dying as a result of childbirth. We're beginning to see more lives saved. And I'm sure that at the time we'll do the review on the intervention of NEMSES, and the states too are buying into it. And we can't sit in the comfort of Abuja and expect things to be done. It has to have a sub-national acceptance. And that is working. So I'm sure that, and it's not just about us, the private sector. The private sector too is on board.
Okay.
So it's all encompassing, but we need to create awareness, and I'm sure that Good Morning Nigeria will be partnering this.
All right.
Thank you very much.
Many thanks, Madam Makunjola, for speaking to us on that, and of course seeing you as a part of this team. I'm sure that awareness is will be properly taken care of. I'd like to get to Dr. Gwaram now to speak about this initiative. Brilliant idea, I must say, and hearing what has been done so far You want to commend the initiative. But I want to ask, are ambulances supposed to be mere transport vehicles or emergency medical centers, of some sort, to take care of the patients while they're in motion till they get to, So these ambulances you're talking about, because I know that of the FRSC is just a transport vehicle, right? So is that what obtains with this initiative?
Thank you very much, and you are quite right. Emergency medical service, emergency medical system is a medical specialty. It's not rescue, is not treatment. Transport is not care. And then so many multiple agencies are doing just that. Because the emergency medical system in Nigeria doesn't have a structure. Since the structure is not very clear, all agencies would key in. They would see it as there is a lapse here, and then they can easily get it. Wherever in the world emergency medical services has worked, it is specifically designed, medically governed, and it's a medical specialty with providers, with fleet management, the way you're going to manage your vehicles, the way you intercept the care you give a medical coordination while in transit.
Okay.
All of these components, they have to be integrated because somebody has to be responsible. There has to be a coordinating agency. NEMSAS, it's a good and excellent initiative. It came in when we have a lot of trouble. As a trauma surgeon working in National Trauma Center here in Abuja, everybody knows it's the final referral center. Everybody, in fact, hands off all treatments. If I'm to tell you the data from last year or from this week, all the patients we've managed in the last 10 years, most of them, if not brought by good Samaritans or brought in by their relations,
Good Nigerians,
it is by the police.
Okay.
The police, they are the most active in this thing, but they are never recognized except by us in the trauma center. Because let me tell you, trauma, all these injuries and these things, they happen late at night and everybody is asleep at that time. It's only the police. Those are the last point of call. If I were to give you just last week, there was an incident, a mass casualty, around 5 a.m. I was standing, they brought in 6 patients, seriously injured. And then we were filled in. So I told them we don't have any more space. Don't let them bring other patients. But unfortunately, it's another rescue team that went and brought in the patients. And then when they came, we told them, the police, that okay, we can't accept this. It was my junior colleagues that were telling them. And they were really furious. The police, they got angry. They brought out those 4 patients bleeding with fractures and dropped them on the floor. And it was myself when I intervened, because initially I was even furious, wanted to argue with the police. But what he told me humbled me, because he told me it was his DPO, a lady in Abuja here, that gave them 20,000 naira to put in fuel, and they went through 5 hospitals before finally coming there, and the fuel is finished. So he was asking me, what do you want me to do? I was confused. The next outside the police is the road safety during the daytime. The road safety, at some time, some years back, funded by World Bank, we trained the road safety rescue operators on just basic life support. These are not medic people. They are just individuals that have been recruited, and then you want to reformat them into doing medical service. It won't work. We are just recreating the wheel. Emergency medical services has a long history. This is something that everybody knows, the history from war, from military, army, surgical hospitals, how they see these things from World War I to World War II. And then now this thing has been delimited, especially by the World Health Organization, that all countries in Africa, in low and middle income countries, they can actually adapt them to it. So if we are trying to do something outside those ambit, we are recreating the wheel, and we may likely run into problems. What I'm saying now, if I am to give a practical example, any response beyond 10 minutes is a waste. If you are talking about emergency, somebody with an ischemic heart disease, somebody that had a heart attack, for instance, and then if you want that individual to actually be revived so that they can reopen the blood vessel in his heart and that individual too, it's about minutes. It's about minutes. And if you want to have any response less than 10 minutes, you need an ambulance, a single ambulance per 50,000 number of populations. Where do we have them? We don't. So yes, there is NEMSAS. Initially, the excitement, we thought NEMSAS is going to be the regulatory and leading agency that would get the necessary act, the funding, the authority, and the mandate, how this thing is going to be run. And then clearly establish it, just like you have established hospitals and the care. This is a medical specialty. You are right. The care, it has to be when somebody is a root, he has so patient. And this patient, likely we have given him so treatment, and this is his condition, these are his vital signs. So we need X, Y, Z from the hospital. Before you come, the hospitals are operated, are ready. If I were to give you another final example so that not to take your time alone.
Go ahead.
I have never, we are ready, we have the surgeons as a chief consultant, that is more than 10 years being a consultant, we sleep in at the National Trauma Center. Why? Because we know this thing is time sensitive. Apart from being a consultant locally here, we had to do a post-fellowship. That is further qualification, post-fellowship in advanced trauma surgery. But I have never operated on a beating heart in Nigeria. And I have been in the trauma center for 10 years. But my first week in South Africa, when we were there in training, every week you would see a patient that is either stabbed in the chest with injury to his heart, that you would just run into the theater, just sew the chest open, and you can plug that injury. And people are surviving. By next day, you would see that person taking spaghetti. In 10 years, we have not done this in Nigeria. So these things are not...
So we're not ready for emergency response?
Okay.
We don't have it.
All right. Okay. Let's thank you so much, Dr. Gwaram, for that. Let's bring in Prof again. Let's look at the buy-in of the subnationals. Now we're talking about the states. How many states have actually keyed into this initiative, and what exactly is stalling it? And do you have enough? I mean, from what Dr. Gwaram just said now, do you have enough, personnel, to carry out all these, initiatives?
All right, yeah. First of all, thank you.
Connection. Professor Brisibe can rejoin us. We hope the connection becomes better. I would like our viewers to know they can be part of this conversation, by the way. The number is on the screen, so you can send in SMS or WhatsApp messages, and of course a guest would respond to them. So
okay, I think the Prof is back. Let's have him.
Yeah, okay. So of course we know that we have is a new thing. The National Emergency Medical Treatment Committee is a specialized committee under the Federal Ministry of Health that is responsible for providing, managing the fourth gateway funds. And within this period, what has happened, most especially in the past 2 years, is that about 32 states have bought into it. And of course, some of these centers, it can't be all the centers, because centers need to be accredited. They need to have a basic minimum standard to reach before they can be accepted as centers that can provide that. It's a rigorous process, and we want it to be that. But again, because we understand that ambulances are not enough, there is strong public-private partnership. So in some states, for instance, in Anambra State, and private people are being made to partner with to provide just ambulances for transportation. And a case in a specific case was when Anambra there was a time they had a public emergency situation where a building collapsed. All the ambulances that were used were invested by private partners. So that is the type of foundation we are trying to build. And of course, in terms of having these results, even in places like Yobe, we not only vehicular ambulances, we also have these keke ambulances that is being done across at the subnational level, where pregnant mothers are easily transported from their homes when in labor or when in any crisis to the hospitals, because one of the critical things is to reduce our maternal and child mortality, which is something that is not giving us good outcomes all over the country. So all that is being done, and of course parents as well. For the past 1 year, there is no state that has keyed in within the 32 states and FCT that had not received prompt payment, because one of the critical things about buying in is that when you render these services and payment is not done, you do not, and of course it's emergency, so facilities are made to spend their money. So if that is not done properly, it becomes a problem. For now, the claims sub unit, I will tell you, over this past 1 year, all the states and their claims have been settled. Not only that, the states will come and be able to tell you. For instance, in Bayelsa, I think last year were claims for the centers that are being onboarded got up to about 30 million. And of course, all the federal tertiary institutions automatically are centers. So that is what we are trying to do to expand this process. The human resources is something that is very, very critical, and we know that we have some deficiencies. And that is why NIMTAC is working with the accrediting bodies to see that we begin to train that critical manpower, most especially in supporting the
connection is a bit not clear. We hope that we can reconnect with him. Let's return to the studio now. And of course, okay, I hear Prof is back.
So sorry, it's network issues. So that pre-hospital transportation is very, very critical. Just like the consultant orthopedic surgeons talked about, presently is basically the police, public standards by, and road safety in my own classification that take patients to hospitals. That transportation, in most cases, if a patient has a spinal problem and is not properly transported, by the time this patient gets to the hospital, of course, it would have worsened the situation. So we need to also
get to Dr. Okonokwa now. I'm sure we'll get to Prof much later. But of course, he's made his point about, efforts made by this initiative. Dr. Okonokwa, I'm sure you listened to Dr. Gwaram speak about all the issues when it comes to emergency response in the country. And I'd like to ask you, in the FCT that you coordinate, what is the emergency response time like when you get a call? How long does it take, before I think you basically transport. I don't think the ambulances take care. But you speak to us about that, how equipped are the ambulances, and then if it's just transport vehicle, and before you get to the centers that are designated for care. And I'd like you to speak about funding for this very important part of healthcare. We hear about budgets, for health. Is there something specific for emergencies? Because even in hospitals, you go to certain government hospitals right here in the FCT that cannot take care of, minor emergencies because they do not have the facilities. So speak to us about that.
Okay, I'm trying to unpack your questions, It's quite loaded. I'm going to start by saying the essence, just like the co-chairman of the NEMTC said, is to save lives. That's the most important thing we do. First and foremost, how do you save a life? Whether you're going to save this life in prime time or you're going to save this life, do you want to save a life?
Yeah.
So what in the present situation we find ourselves, the most important thing we do in order to take it out from the hands of the Okada man or the man who is a bystander is to do what we call scoop and run. So first and foremost, just take this patient as much as possible and convey to the nearest healthcare facility. Now, we're going to leave that at the doorstep of the consultant. Basically, a lot of the ambulances that we have in the FCT currently are, basic life support ambulances, just to sustain the patient from the point of the incident to the nearest healthcare facility. So yes, the ambulances, they are basic life support, so they can also provide some level of care. Those are the ones that we have accredited. Okay. Now, the ones that the road safety may provide, just like the consultant said, these are persons who were given minimal training so that they can render service. They may not be healthcare providers, but they are drivers, or that level of service providers. So for the services that are rendered under the FCT Emergency Medical Service and Ambulance System, all the ambulances are fully equipped to provide pre-hospital care before you hand over to the consultants in the hospital. The National Emergency Medical Service and Ambulance System is one of the gateways through which the Basic Healthcare Provision Fund provides care to Nigerians. There are about 4 gateways. There is the NCDC gateway, there is the primary healthcare gateway, there is the health insurance gateway, and then there is the EMT gateway. These are fully funded, and it is a constitutional matter. Okay. A certain percentage of the budget at the national level is set aside for emergency care. Okay, and I think at the last time it was 5%. So this is fully devoted to emergency medical treatment and care, whether it be from the point of picking up the patient to the point of providing care for the first 48 hours, is fully funded. So there are funds already set aside for these services. Now, when you come to the individual hospitals, that's another ball game altogether, because we know that there is competition for funds in all these healthcare centers, whether it be primary, secondary, or tertiary. If, for instance, just like the case that he cited, if so much funds were available, there will be no reason to reject an emergency patient. There will be no reason to say, okay, we've had enough, we can't take more. But that's because we're also constrained by funds at all levels. So it will be foolhardy of me to sit down here and say that, oh, it's all rosy and it's working perfectly well. There's a lack of resources to be able to meet all the needs. But the point to be made here is that if we look at where we are now and where we want to go to, we must make some level of movement. We must move the needle no matter how little. And that's why I say, even if road safety, in an ideal situation, the police should not be involved in emergency care. In an ideal situation. The police is mostly set up to provide security. But because we're in a serious situation, that's why you see the police moving an accident victim in a Hilux vehicle at the back of a truck. It is not an ideal situation. But are you going to say, okay, let's wait until it is ideal before you start moving patients? So you will not say, okay, things are not ideal, it's not rosy, and then we condemn it totally. It is still a step, forward. In an ideal situation, Federal Road Safety Corps should not even be involved in conveying patients from a scene of the accident to the hospital. But that's where we find ourselves. But they are playing a role. Now, let me also let you know that even at the community level, we are also having to leverage on the services of the National Union of Road Transport Workers to move the woman who is at the point of delivery in her home to the nearest primary healthcare center. That is also moving the needle in terms of emergency care. And these are all steps that are geared together to ensure that things work properly. Why are we talking about Keke and Pep, or why are we talking about Keke and Ambulance? Because if you go to some communities, access roads are not okay. The infrastructure is not there to have an ambulance, whether it is basic life support or advanced life support, that is a 4-wheeler, moving around in such neighborhoods. So you need something that would be able to help that woman in need. And that's where we also use, tricycle ambulances, because it's easy for them to navigate. Before now, they were moving women in wheelbarrows.
Wow.
They were moving pregnant women in wheelbarrows. And yet they saved some lives. But now we're moving a step further and say, okay, rather than use wheelbarrows, give these women some level of dignity. If you cannot afford to make the road more tolerable, at least use a tricycle ambulance. Now, where the situation is so tight and difficult, where there are not enough, tricycle ambulances, we are leveraging on the National Union of Road Transport Workers to use their own vehicles that they would have rather used to convey passengers from point A to point B, to quickly go and pick up a woman who is in labor, because we also leverage on the network of the community using the World Development Committees and the Neighborhood Watch to ensure that the woman who is in labor in the local community is able to put a call across to a number, and then a vehicle, no matter how rickety it is able to convey this woman, because a lot of them are dying in the process of either walking, trekking, or being carried on a wheelbarrow. So National Union of Road Transport Workers is also in this. So there's a lot of stakeholders involved in all of this to ensure that what we were experiencing some 4 or 5 years ago, we're not going to be experiencing it, this year. We commend what the federal government is doing in this regard, because but for the intervention of the National Emergency Medical Service and Ambulance System, a lot of persons would have lost their lives, without the initiative that this is putting on the table. We have been able to, I must say, move the needle a lot. The FCT is doing the bit that they can do. Only recently, the Minister of the FCT, procured about 12 new ambulances, to add to the fleet of ambulances that we have, so that
making a total of how many?
It's not just the number of ambulances that the FCT has. The total number of ambulances that are available in the FCT, including private ambulances, are also in the fleet. So every hospital that is in the FCT, their ambulances are expected to be part of this scheme. If, for instance,
are the ambulances fully equipped? Because you're saying all the ambulances, even in private hospitals, are they well equipped?
Now we accredit. Before we can onboard you, we do an inspection of your ambulance, and it must meet the minimum standard.
Okay.
If it doesn't meet, we're not going to onboard you, into the scheme. That doesn't preclude you from rendering your own service. But for you to be a part of the emergency medical service and ambulance system, you must meet some basic minimum requirements of ambulance, both the ambulance itself and the staffing.
All right. Thank you very much, Dr. Okonokwa. Mrs. Makojola, earlier on you talked about, that there has been a reduction in the rate of maternal mortality, especially in the hard-to-reach areas. And some states still have these high, mortality rates. And this initiative, it's a bit difficult for you to reach out to them. Is there any collaboration with the community leaders? Maybe the social workers in those areas?
I think I'd just like to go back a little, about the challenges that every discussant has spoken to. It's an emerging intervention.
Okay.
So the basic global standards are not there yet in terms of what we're doing, but there's a starting point. And the starting point is where we are now. Like he said, there must be people who are trained specifically to be able to man an emergency when it occurs. I'd like to just give a little history of an emergency situation that I witnessed outside this country. Within 3 minutes, the ambulance had arrived, a helicopter had arrived, fire brigades, the fire brigade had arrived, and the patient, because we followed through, it was close to a hospital that they could quickly rush to. And we found out that that patient needed some kind of intervention while they moved from the scene of accident to the hospital. There were medical personnel that were doing that. I'm not sure if we are there yet, and I'm sure that's what you're talking about. But the basic things that we know, the peculiarity of things that we take lives away, from Nigerian and gives us these high incidences of maternal mortality and the rest of it, is the fact that we are singling out health as being responsible. And it's not just about what the healthcare sector brings on. If there are no good roads, there will be delay. And like you said, any delay past 10 minutes, it's a risk. If there is no awareness created, people don't even know, even if you are having an integration with the NURTW, that's the Road Transport Workers Union. If you don't know that it exists, we will still keep losing people.
If there are no functional primary healthcare centers. If there are no
functional, yes, if the facilities themselves are not there. Like somebody called yesterday and said, Auntie Woju, we went to a facility, do hospitals go on holidays? And I was, no, it's a 24/7 intervention. So these are things that, we must deliberately ensure that we have an engagement and create awareness for people to know where to go, what to do. I know that in those days, they used to teach us what you call first aid, how to apply, at least keep the life running until it gets to the specialist. But I don't think we have that on now. And I'm speaking from the point of a health advocate, that we need to start putting some of these things in place, creating such awareness that people will tell, look, this is where to go when you have this. We have market days, we have market women, very organized. The Nigerian Union of Transport, they have done very well, and we have cases where they've done well. Jigawa State stood out, where the transport union workers became an integral part of these emergency intervention. So it is doable. That's the joy of it. It is actionable, but we can also do it. We want to attain global standards, but we also have to look inside, and bring out concerns or interventions that are peculiarly us, that can address our situation as a people, without losing sight for global standards. And, our dream will be to get there. But whilst we are not there yet, there are interventions like NEMSES is doing that we can be part of. And it is not that of the Federal Ministry of Health alone. It is that the sub-nationals must be serious about this. The states, the rural areas, that's where our majority of Nigerians stay. So if you are there and you're not sure of some measure of quality in terms of health when there's an emergency, then you have failed the people. And this is why we must create awareness for people to ask. We are going to be listening to our politicians now. When they promise us good health, we must ask, do you even know how it operates? Do you know that emergency intervention is an essential, is an imperative to have this equitable healthcare delivery service that we speak to every day? It's not, and individuals also must be stimulated to be able to contribute to this. It's an all-commerce thing. When you now want to donate ambulances, you just don't go and get a bus and get things fixed. You must be able to speak to the experts who will tell you these are the expectations, this is what the bus should contain. You must also be involved in sponsoring an emergency specialist, medical specialist. I hope that as we listen, it's about academics, it's about us, it's about the selfless service that we can give. If you are, for example, building a hospital that you hope can take in emergency patients, if you build it in a place where there is no road, you will find that lizards and the rest of them are inhabiting that place. So what I'm saying here now is, yes, we must, as a matter of urgency, create an awareness that is all-encompassing. Our philanthropists also must hear this, and I hope you're listening, that government alone cannot do this now. Investors should also be part of this. Because there are people in Nigeria that I know are interested in having emergency standard interventions themselves. But they must be able to listen to the chief consultant, like he was saying that, okay, we have NEMSIS, these are the standards. If you fall below the standards, you cannot be accredited to operate, to give service. So it's, as we go on, as we evolve and we let this on, especially with the health reforms of the, and the ambition of the present administration to provide health as at when you need it, then we must be serious about ensuring, even as we go on, that standards are made and Nigerians are aware of the standards.
Okay.
So if you bring in any vehicle that is not, you might be able to say, no, okay, we'll use you for now, but don't bring this back.
Many thanks, Madam Makonjola. Thank you so much. Let's get to Dr. Gwaram now. You spoke earlier about facilities that are not available. Let's speak about the personnel. How does brain drain affect our emergency response capacity? And speak to us about you're a surgeon, you're with the National Hospital. We've heard cases of patients even being brought early to certain facilities, but not being attended to. The attitude of medical personnel in dealing with emergency cases. And also speak about a situation where even when the medical personnel are present, but they just don't know what to do. Speak about, is it, I don't know the term to use for it now, is it incompetence, such that a patient is brought in early, but the wrong things are being treated. Eventually when they get to the right facility, it's already too late. So speak about all these issues amongst medical personnel.
Thank you very much. Like my brother, your questions are loaded, so it's a good thing. It's a good thing you are not an examiner. You'll be failing people. But really, these are the practical things that are happening every day. And if I am to tell you life experience, every day we are dealing with these situations. The brain drain, I'm just going to lump it all together and give you maybe a case situation. The brain drain itself, the incompetence, the lack of proper attitude to work. Emergency services, we will try as much as possible to make it into something that we can either, maybe what the government is ready to provide. We would work with it, work with National Union of Road Transport Workers, work with ambulances, private ambulances and things like that. In this same show, Good Morning Nigeria, a long time ago, you had a program on this issue of organ trafficking.
Yeah.
Yes. It's a vexing situation in Nigeria. It's still happening. But if there was a proper emergency medical service, do you know even the patient that dies on the scene, if they are intubated and their vitals are maintained, if you take them to a facility, they are brain dead, they are dead, normally dead, but the other functions of the body, they are going. You can harvest their organs and transplant. Because a single person, if he dies on a ventilator, in advanced societies, everywhere, in African countries, it's happening. You would get 2 kidneys, you can get a liver, you can get a cornea, you can get intestines. You would be saving others. So this thing is not a contraption. This thing is not, so I told you, it's a medical specialty. Okay. If you want to reap the benefits of it entirely, it's not that somebody, it's not a situation, it's just like a 3-wheeled car. Okay, we have so amount of this money, so make sure you provide these services. Okay, we can only provide these services in this place. If it is a medical specialty, we can only do this. But if we accept a responsibility, then that is why we start pushing that market women should help us, NURT should practice medicine. It won't work. Then the situation from the federal ministry should be legislation, authority, guidance, oversight, and things like that. There are, in the last 10 years, University of Abuja, University of Port Harcourt, there are over 10 teaching hospitals in Nigeria that are offering pre-hospital training. There are paramedics, thousands of them in Nigeria. They don't have a job. You can easily reformat nurses that are trained in basic nursing. With 3 months training, you can reformat them into paramedics. These things are known. These things are done. These things is not our own creation. There is a standard way of doing it. If we try to adapt it to our system, all the benefits we are supposed to reap, we will not reap it. We would rather be just, it will be a Sisyphean project. It is going to be effortful, but it's futile.
So how can emergency responders, be better equipped and, trained to handle, large-scale emergencies? We have noticed that when you get to the scene of emergencies, you see a lot of crowd, people crowding the place and making it very difficult for respondents to work. Yeah. What can be done? But we just hold on there. We'll take a break now. When we come back, you respond to it. Thanks for staying with us. You're still on to Good Morning Nigeria on the network service of the NTA. And the discussion is still on Nigeria emergency services. And our guests are still here. And just before we went on that short break, we're asking Dr. Ogwaram to give us... We already have questions and comments, which we'll read out. But I just wanted Dr. Ogwaram to respond to the question I asked before we went on the break. How do you, train and handle, immediate responders, especially when it comes to large emergency cases?
Thank you very much once again. We've had a lot of challenges in Nigeria, and getting the numbers, if we have a system, as a medical system, the numbers of those trained personnel into an established system, it's not going to be much of a problem. If you have where you are training these individuals and where they work regularly and where they are supervised, and every day there is a drill, just like a military drill. If there is any misstep, it is picked. Okay. If there is communication online, everything recorded now with all the technology available, all of these things would be a thing of the past. It answers the same thing, the question she asked earlier about people living. A lot of healthcare providers, one of the things we miss is a lot of people are not living because of the welfare issues that a lot of times people are assuming. You have this knowledge, you have these skills, it's like you are imagining heaven, and then you get somewhere and then you get to see that heaven. You are trained as a nurse, you are trained as a paramedic, and then you have an opportunity to rush, save somebody, and then you go back to your house, live fulfilled. That's the word, sir. You would be fulfilled. You would sleep like a baby, and then only to wake up. People would be doing this thing with passion, with emotion. But this thing, it would take out the system, the way it's operating. It will take this out of you. That is the same thing about the attitude you are talking about. I assure you now, you would see there are so many committees in every hospital. He would bear me witness for lapses by nurses, by doctors, by everything, one committee or the other. But you see, at the end of the committees, they will tell you you have to work, because by the time you subject any incident, there is a way you check any mishap in medical practice. If you check it, is it an infrastructure issue? Is it a communication issue? Is it policy issue? Is it training gap issue? Is it if you put it through these scales, you would find out that the person there is likely less responsible than the institutional challenges. You've seen the sensational nurse that was rejecting a patient, and then they were in a shouting match. Because a lot of times, there is nothing more frustrating than to receive a patient you can't do nothing about. You have been through this thing over and over, maybe for 10 years. You know how it ends. You collect this patient. So if there is a way, if there is any window that you can divert that responsibility, they will divert it. Because you know you would accept this responsibility and then it is going to be a problem. Just like I'm telling you now, I will tell you the truth. And I'm on thin ice here. If you go to a hospital now, you bring a patient, there is an existing rule in this country that all gunshot wounds should be managed. If you don't do it, that even you are culpable. There is another rule for the hospitals that you don't have any right to hold a patient back if he is healthy, telling him that he is going to pay to reclaim your money. You have to let him go. And these two laws, the hospital now, they have to run themselves on their internally generated revenue. If NEMSAS or anybody brings a patient, now, as we speak now, I have more than 3 or 4 patients that are brought by police. You call the police, they will not pick the number. They will not pick. And the patients are there. We are the ones feeding them. With my doctors, when we do round, we collect money. We feed these guys because they were criminals or they were victims of crime. And then a lot of times, we are the people that, because their clothes are shredded, we are the people you always go to work with a spare cloth. That is why I wear cheap clothes. You understand? So that you dash into another patient. You understand? So these are the practical things. Now NEMSAS, they say, okay, within 24 and 48 hours, they have taken care of the payment of this patient. What they have taken care of actually is the things that the hospital doesn't have to buy. Like if the patient is going to have X-ray, they will bill it that they have done it. If he wants a brain CT, they will do it. If he needs a blood transfusion, if there is available blood, if there is, otherwise we would wait and then we will be the people looking for a donor to give that person. Now, anything else, his medications, consumables, gloves that you're going to be using, gauze, all the things that need to be procured, his catheters, all the other things, they're not there. They are not ready.
So how do you provide that?
So you see the challenges now. That is where now the devil is coming out from the details. You understand? The hospitals are supposed to provide these things, but they are constrained because it's a system in procession. Now, if you imagine a nurse, she has been through this thing for 5 years. She knows how this thing ends. By the time any police comes now in National Hospital to bring a patient, he is frustrated because he doesn't want to do that. And the moment he brings them, they are already apprehensive because they know this person, he doesn't have relatives, there is no source of care, and you have to even apply to the compound matron, then to the management to get clearance before you start treating him. In this program, there was a person that gave a press conference how we took care of him at the trauma center. He was shot, and then one of his grounds with us was that the gloves that he purchased by himself, that some of the nurses picked some of them and then they were helping another person. You understand? So it's a very big issue.
It's a big challenge.
If you get people, there is nothing more frustrating than giving somebody responsibility without authority or without the necessary equipment.
Do you think funding is the issue of mismanagement?
Funding and refunding. If I am just to rephrase that, you see, there are lots of reforms getting in. So most of them are targeted at blocking leakages and to transform the payment system and everything into digital and things like that. But a lot of the things that happened, then they are stifled. Then it makes delays, serious delays in getting your money in procurement. If you go to the management, you see how their hands are tied.
No doubt, Dr. Guara, the challenges in the health sector is among us. I mean, it takes a lot. But let's read out some of the questions and comments from our viewers so that our guests can respond to it. Probably we'll go to Prof to respond to some of these comments and questions. This one says, good morning, sir. If this emergency service is really effective, effective, it is laudable. That is, if it is effective, it's laudable. This one said, good morning, panel. My name is Abbas Abubakar from Jalingo, Taraba State. There are many challenges, especially in the rural areas, when it comes to this issue. One major problem is the poor condition of roads. Just like we stated, the government needs to also focus on fixing rural and local roads. I recall an incident where a pregnant woman was being rushed on a motorcycle during an emergency. Now, this one is from Josman. Josman is from Kwara State. It says, good morning, Nigeria. One of our major problems is embezzlement and diversion of funds for personal use. We need to reorientate ourselves and put a more harsh penalty for perpetrators. God bless Nigeria. This from Bemisola. Bemisola says, good morning all. The concept of the Nigerian emergency response is a very good idea. However, what is the plan to address the drawback, such as manpower shortage, ill-equipped ambulances, timelines in service delivery? This from Engineer Augustine Ijame. He says, I wish to suggest that it is important that the consultant mentioned some key activity that is peculiar to South Africa and other countries. I think we should ask, what do Nigeria Trauma Center require to begin to attain the level where other countries are today? Do we have the human capacity or human capital to do that? Do we have the equipment, the resources, and so many other things? Okay, Prof, you want to respond to some of these comments and questions, sir?
Thank you so very much for giving me this opportunity. Most importantly, when it comes to emergencies and the Nigeria ambulance services, I must give it to the renewed agenda of the president and also the leadership being given by the coordinating minister. We've made a lot of progress. For instance, of course, let me reassure the person that asked if these emergency services are working and that if it is working is good. I must reassure you that this is working at this point in time. I'm the co-chair and also the chairman of the claims committee, and I know that states are bought in. And not only that, I'm a commissioner of health. So even at the sub-national level, a lot of states are contextualizing what we're doing. There are innovations. For instance, in places like in Bayelsa State, about 70% of the state is waterlogged. So the governor had innovated a system where we strengthen our boat ambulance system. Not only that, just by 1st of this January this year, the NEMSA's office created a digitalized platform where 24 states, as we speak, have emergency numbers. They may be 11 digits, just Lagos and Oyo that have 3 digits. Lagos is 767, Oyo is 615, but 24 states, including my state, of course, have emergency 11-digit numbers. And those are the critical things we need to talk about. We need to educate our people that these numbers exist. So when there is emergency, they call. Not only that, there are states that have gone beyond that, because at the national level, what NIM is to do is to ensure that
Many thanks, Prof. The connection is not too friendly this morning. We hope it gets better. But I'll just read some of the comments I have, comments or questions, whatever they are. I'll read them quickly. Now, this one says, good morning, Nigeria. This topic being discussed today is apt. It's great knowing that Nigeria has started emergency response services. The awareness may not be as expected yet, and the performance may be minimal for now compared to the world standard, but Rome was not built in a day. The world standards we point to today started a little as well. I believe we're getting there and we'll definitely grow better. God bless you all. God bless the emergency responders. God bless the Federal Republic of Nigeria. Omolubi A sent that. This one says, for medical emergencies, first aid is a critical link in the chain of survival. Bridge the gap until paramedics take over, potentially making the difference between life and death. That's Nanda Muyep from Jos. Another one says, good morning, Nigerians. Emergency response unit in every hospital is a department that should not be handled with kid gloves. Government and various stakeholders should provide enough ambulances and qualified personnel to man that unit. That's from Chris Simon. Another one says, good morning, Nigeria. Why the reason people attack emergency responders is because they come late, especially when there's a fire outbreak. What role does access road play to prompt response? Oh, well, that's been talked about. Ibrahim Biu from Borno State sent that. Another one says, good morning. My name is Emewulu Justin Chinedu, living in Enugu State. I'm very happy about today's topic. Taking accident victims to the hospital in my state, Anambra and Enugu, where I live now, is not a problem. Government is doing well. But the major problem is that the doctors and nurses will not start treatment without paying or depositing huge amount of money. Then you have to pay for emergency card, which can take a lot of time, and a long process of paying the money and getting the card would eventually get the accident victim dead.
Okay, Dr. Okonkwo.
All right, thank you very much. The last comment is exactly why NEMSAS was set up in the first place.
Okay.
And I think critically, one of the challenges that we have is the communication gap between the emergency service provider and the hospital. There's a link, and that link is communication. Now, between that communication, we have the Nigerian Communication Commission. Ideally, once you call the 112 number, an emergency responder should be notified. But there's always a delay. Sometimes it happens because when you call the 112 number, the 112 number is the emergency communication center. Now, they get the calls and then transmit the calls to the dispatch centers in the state. Now, that is where the challenge normally comes from. You know, so a patient calls, let's say at an accident scene, you pick up the phone and you dial the 112. It is toll-free. So they get the call. Sometimes there's a delay between when they get the call and when they transmit this call to the ambulance service provider. So that is why he may have a challenge in getting that 10 minutes, timeline. By the time we get the call, and I just want to quickly address the issue of when people are attacked, because if you call an ambulance and it takes them 30 minutes to arrive, of course you would be offended. But the problem is the ambulance service provider doesn't get the call early enough. The time the ambulance service provider gets that call and to the time he or she responds, gets to the scene of the accident, usually less than 10 minutes. I speak for the FCT. But by the time we get there, they will tell us, okay, we placed this call like 30 minutes ago. So they get offended, and they may take
Why does it take so long for the ambulance to get?
Ideally, once you call that 112 number, now the 112 number is meant to patch that call directly to the emergency call center. For instance, the FCT emergency call center. That shouldn't take up to a minute. Now, but there's always a delay. When that delay happens, when we get the call and dispatch an ambulance. Delay?
Who is responsible for that delay?
Now, the delay comes from, I'm going to call out the NCC here.
Yes, do.
It comes from the NCC. And it comes across the whole nation. If you call Jigawa, call Yobe, call FCT, call all the states, they have this issue with the NCC. Now, so that's an issue we really need to address. So that is why you find most states resorting to the 11-digit number. Mm-hmm. When you call those...
Which is direct.
Which is direct. So when you call the 11-digit number, you get response faster. All right? Because you're calling the dispatcher. So he's able to dispatch an ambulance quickly and then move to the scene, of the accident as the case may be. So
why is FCT not going the 11-digit way? Why are you sticking with it?
We have 11 digits.
Okay, can we have that number?
Okay, in the FCT we have 091 56789 2932.
Say that again.
091 5789 2931. And then the second number is 091 5789 2932.
All right. Thank you very much, Dr. Gonokwa. Because we have to round up now, let's just, in just 60 seconds, Mrs. Makojola, what do you think are the takeaways from this conversation this morning? The
takeaway is that it's actionable, it's workable, but we have individual responsibilities. Like, for example, finally, make way for an ambulance on the road. An ambulance comes beeping and all that. People are saying, we're not sure whether it's just, you have a responsibility to do that, to ensure that they have a free way because of an emergency they're attending to. And of course, to say that, well, we need more funding. It's a collaborative effort, good roads, good human beings working with a passion to ensure that more lives are saved.
More funding, both from government and from private sector.
From private
Dr. Guaram, in 30 seconds.
In 30 seconds, we are already paying the price in lives lost, in economic viable young individuals dying, in the loss of revenue that people are traveling abroad to go and source with our own hard-earned money, trying to sort expensive health care. And Nigeria, we can afford it.
Okay. Nigeria can afford it, so we just need to do the needful. Professor Brisbane.
30 seconds.
Yeah, I think that is a collaborative thing, and I want to encourage all Nigerians to key into what is provided by government, ensure that you are a stakeholder. All of us are here in the business of saving lives, not only saving lives, improving the health quality of all Nigerians, because all Nigerians are brothers and our friends. So I want to encourage Nigerians, for those that have heard about it, please tell your neighbor. If you see something, say something. If you see something, take action to see that that life is saved. I want Nigerians to have this attitude of saving lives. Create roads, access roads, don't overcrowd emergency spots. Once you see any emergency,
thank you so much, Prof. We're out of time. Professor Seifa Bresibi, Honorable Commissioner for Health, Bayelsa, thank you so much for being our guest. Dr. Usman Adamu Guaram, Chief Consultant General and Trauma Surgeon, thank you, from the National Hospital. Dr. Konokwa Ozi, Program Manager, FCT Emergency Medical Service and Ambulance System. It was a pleasure to have you. And of course, our very own Madam Ojima Konjola, Executive Director, International Society of Media in Public Health. Thank you so much for being our guest, ma'am. We appreciate you. So that's our package this Friday. Thank you so much for watching. Live it locked on the NTA. I'm Ian Ray John.
And I'm Ademola. You do enjoy your weekend.